I'm Dr. Adam. Good afternoon, everybody. This is Dr. Adam, just like Ms. Mary said. Just wanted to correct one thing. I've been in practice for about 11 years, not 5. I think that's a old typo, but it doesn't make a big difference. Yes, as Mary said, this topic, it doesn't usually get a lot of attention. Our patients might report it and might not report it, so it might go undiagnosed for some time. So we'll start with the information about postpartum depression. Mental health condition affects about 1 in 5 people during pregnancy or postpartum. It can happen, like I said, during the pregnancy all the way to the first year after having a baby. Despite a lot of approaches to detect or screen and treat patients, these condition can still go and recognized and also untreated. Significant short and long-term effect on both mom and baby that can take some time to evaluate and treat, but at the same time, if we catch it or screen it early, we can actually get ahead of the postpartum depression. The depression during and after having a baby, 1 in 7 patients. The onset can happen preconceptually before the pregnancy, and also happen during pregnancy and during the postpartum period. And as you can see, during postpartum period is about 40% compared to 27% prior and 33% during pregnancy. It's kind of split 1/3 almost for each station of the pregnancy. Over the last decade, the percentage or the prevalence of mental health condition had increased substantially across the United States. And there's a lot of reasons which we'll go over. Pregnancy tend to be more susceptible to anxiety and anxiety-related disorder compared with postpartum patients, and therefore anxiety is a strong predictor or indicator for postpartum depression for some patients. So that's something, one of the red flags what we deal with and we see commonly in our patient. Women, some of the risk factors and some of the etiology, again, patients, the main reason that postpartum hemorrhage is encountered is usually this significant change in hormone levels, but patients also who have significant history personally or in the family who has anxiety or depression have about 2-fold increase in their antenatal depression. Some patients also, the unfortunate partner abuse or the lack of support, stressful life events. Sometimes they work, they have school or they have college, and they end up getting pregnant. History of personal anxiety and depression, including history of psychotic treatment or diagnosis during prior pregnancy. That can also gives us an indication that the patient is at high risk of having perinatal depression. Again, some of the risk factors that we see very frequently: young patients, veteran dependent status, some patients are active duty, unemployment, incarceration, lack of sleep, or any other sleep issue that the patient might encounter. Just a briefing about for people who don't know what the postpartum period usually is known about 6 weeks after having a baby. 50 to 80% of the patients experience something called postpartum blues, which is usually, it doesn't last more than 2 weeks. About 0.1 to 0.2% of newly mom can experience psychosis up to 4 weeks postpartum, which is a very alarming diagnosis. Postpartum depression can occur not just the first 6 weeks, even though it's defined as the postpartum, but it happened within the first year after having a baby. 6 to 16% of mothers experience postpartum depression. So that's, again, a significant number. Potentially having postpartum depression can affect, of course, the relationship between the partners as well as on the baby himself. Studies showed moms who have postpartum depression, they have infants or babies who have delayed cognitive and psychological development. Plus here, they're less vocalized and they have delayed motor skills as well, which will lead to more healthcare resource used on the infant side as well. So what are the most common symptoms that we experience or we see with our patients who come in? So they report feeling hopelessness, helplessness as well. They feel sad most of the time, irritable, low self-esteem. Even they might feel anger, resentment toward the baby, which might lead them to think of having some thoughts of harming the baby. The loss of pleasure for any activity that they used to enjoy prior to the pregnancy, mood changes as well, sleep, disturbance, as well as change of in appetite. So I'm just going to go back a little bit here before I go to the next slide. So that can differentiate a little bit between, that could be very vague symptoms for our patients. So postpartum or baby blues usually happen, as I said, the first 2 weeks of the postpartum period, and usually they're not extreme. They're very mild symptoms. Patient just feels almost overwhelmed. She might just have disturbance in sleep, change in appetite. She might find herself cry a little bit. So these things, sometimes they're self-limiting and they might not need a lot of intervention. And most people will cope with that and then come out of that, baby blues within that 2-week period. If they experience self-harm thoughts or ideas for themselves or for the baby, that becomes postpartum depression at any time during that postpartum period. Because again, that's an extreme symptom that we need to be aware of. So again, all the other signs or symptoms, they could be very mild and they don't have to be alarming if they're within the first 2 weeks, except if they have any thoughts of harming themselves or the baby. That's usually need to be addressed much faster. So what do we use? The most commonly used that we have for our patients is the Edinburgh Postnatal Depression Scale. That's the one I'm going to be focusing on. That's usually given to our patients in multiple occasions. Patient usually gets that survey right after delivery within 24 hours after. That's an initial screening to tell us how the patient might feel, gives us some maybe red flags or give us some ideas that the patient might need help. So it could be, very mild, initial symptoms. So we can also focus on why she might have that problem and try to identify it before the patient goes home. So for instance, if the patient's having difficulty because baby's not latching or she's having difficulty with breastfeeding, so we can arrange maybe breastfeeding consultant or a home nurse to help the patient. We also try to, make her understand that it does take time. It does take a little bit of learning curve for both her and the baby to start to actually get the latching what she likes it to be. The same thing if the patient can be identified, she needs financial or some support, trying to identify if she has good family around her or friends circle that would be some good help. So that's usually the initial screening tool that we give the patient right after delivery. Those patients, again, if they show any signs of depression, would get all the resources. A social service usually gets consulted, and then usually we'll have them follow with us in a shorter period of time than just the 4 or 6 weeks after the postpartum. Patient also, again, can start to show some signs even before getting discharged. Some patients, they start to not care as much for themselves. They don't have a lot of energy to get out of bed. They don't have, the interest to take care of the baby. So all these things can start to show us early signs so we can intervene and try to help the patient before she gets discharged. So if we don't ask, we don't get answers and we don't know what's going on. So the first question we ask the patient after we check on how she's doing postpartum, is she overwhelmed? Does she feel like she's doing okay? Do you have any thoughts of hurting yourself or your child? And that's usually not a very, upfront question. If we start to notice that she has any signs of exacerbated baby blues or maybe postpartum depression, passing that 2 weeks, then that question comes to mind. Have you the thought of harming yourself or your child. And if you have any difficulty adjusting to the new role as a mother, which brings me to, something that we tell patients usually initially during the prenatal care, the expectation, for being a new mom or being, even a second or third time mom, that's this is going to be changes. It's going to be expectation that, different from maybe what she's been told or she was aware of, either through the internet or the social media nowadays. So try to give her more realistic idea of what's motherhood like. Going back to those questions, if we do have any question or concern about this mom with postpartum depression, we try to give the resource to have public health nurse or healthcare provider can see them for postpartum depression. The Edinburgh Depression Scale that I was talking about, it's a very good tool that we use. It's sensitive, but not very specific. What does that mean? So it does identify most moms or patients who have depression, but also identify some moms who are not depressed. So which lead to sometimes getting more patients screened by the health or mental health providers than we need to. It can also be read initially very quick to score and very quick to read and go over the patient. And I have a copy of it here so you guys can see what it looks like. So basically, again, it can be done before discharge, during the first couple of days postpartum. Also, some pediatrician, they do give it to a new mom, since most of the new moms they see their pediatrician sometimes more often the first few months than their obstetric provider. Therefore, it's also a good place to get screened. And then as well as they get screened in the postpartum period, which is 4 to 6 weeks after delivery. The questionnaire is very simple. It's 10 questions. It can be completed in 5 minutes. And usually, again, it gives us a little idea how she's doing in the last week or so. One good idea that's when I was reading and preparing for this presentation, it's giving patient time to do it in private. So not to kind of sit by her side or trying to lead her to answer the question in a way she doesn't feel pressure. So give it the screening tool or the scale and say, fill this out. If you need any help, we're here. If you don't, I'll be back in a few minutes. So again, give her the time so she can actually answer the question honestly without being pressured. The other thing, I'll come back to it in a minute. Interpretation of the score, usually anything more than 19, most likely is signs of depression. Now, unless they answer yes to question number 10. So as you can see, those are the questionnaire. The last question will ask if they have any thought of harming themselves, has occurred to them, and if it says yes, quite often, sometimes, hardly ever, any of those answers will be positive screening. So even though it might not score 19 on the total scale, but if they answer anything beside never on the last question, usually it's a red flag for postpartum depression. And that's the back end of the screening tool that we have. So again, if the patient at risk, again, based on the scale, then again, the patient should be seen by the PCP if they do have one. If they don't have one, sometimes we try to arrange that for them as well, or try to help them find a PCP in the area that they can see them in a short period of time. If the patient much higher risk, again, if she answers yes or anything but never on the last question on that scale, then the patient should be probably contacting, or we should be helping her to contact the crisis line, or even go to the emergency room for more psychiatric evaluation. If the patient has history of any psychotic disorders or problem in the past, then probably refer them to the health authority as well. Multiple options for treatment or managing of our patient in the postpartum period. It's the counseling, either individual or in a group. So as I was mentioning earlier, since we screen the patient early before discharge from the hospital after delivery, we do have a lot of local resources that we give the patient for group counseling as well as access to individual counseling. Most of those groups or counseling can be actually free or can be, at a very little cost for the patient. Sometimes actually supported by a lot of community groups. And again, one thing I need to mention is identify or tell the patient these issues are very common, because one thing the patient will have in mind, it makes them look bad, it makes them look like they're not being good mothers, or they're being looked at in the community in a wrong way. But to tell the patient or to even have family members, this is very common. It's very normal response sometimes with the postpartum blues or the baby blues, even the postpartum depression, with a lot of the changes that mom has to go through the pregnancy, and after, it can lead them to be overwhelmed. So it doesn't make them a bad person, a bad mother, and kind of take that idea of being depressed. It's actually a bad thing. It's very common. It's manageable as long as we can actually screen, identify, and treat sooner than later. I tell my patient individually when they have any signs of depression. It's if they don't want to go see a counseling because they don't have the time or they don't have their the energy to go see somebody, it's find somebody in your family member or in the close circle that you have, your friends, and just tell them that I want to talk to you about something, and I just don't want to be judged about it. I just want to vent out. Just I want to be heard. And even let them cry. That's okay. So that just exactly what counseling most of the time is. So just need somebody to listen to and understand that these things do happen. And again, if they do prefer to go see a counseling, either individually or in a group, that's also the next step. Support groups, again, there's also a lot of support groups, either in the community or online, that the patient can attend. And I put some postpartum support, either international or even close by here in the United States, and patient they can have access and they can log in and join some of those support groups as well. Lastly, pharmaceutical treatment. There are antidepressant that can be used. I know there's always a concern about breastfeeding. Is it going to affect my breastfeeding, decrease my milk production, or is it going to affect the baby? All those questions, if the patient is breastfeeding or interested in breastfeeding, should be addressed and to be clarifying for the patient, so the patient can feel more comfortable. And also to emphasize to the patient, even though we do support and we do strongly recommend breastfeeding, sometimes these things have to be reevaluated for the patient's well-being and health. So one FDA treatment was approved, Zoradolone, which was approved by the FDA not long ago for postpartum depression. It can be taken for 14 days. It does pass through the breast milk. We don't know how much, or there's unclear evidence of how much can affect the production of milk, as well as how it's going to affect the baby. As I said, that needs to be discussed with the patient, regardless of what medication we use for our patient. The most common side effect, it can cause some dizziness, fatigue, drowsiness, cold-like symptoms, and UTIs. The patient should be on some form of birth control all the way till about a week or two after even stopping the medication. This way to prevent taking it while pregnant. So again, mental health professional can talk to our patients about the feeling. We have to understand, or let them understand, this is exactly what is somebody who they need to talk to about their feeling, to discuss how they can manage them. And that's what counseling is about. And again, this could be short-lived, and it could be something a little more than a couple of months. Some patients can experience, like we mentioned, up to a year after postpartum. So reevaluate the patient after 6 months to a year to tell them if they're interested to come off medication, something to be, tried. If they'd like to try that, you can stop the medication, see how they're doing. If they feel good about it and they're still happy about, taking it, they have other mild issue that they want to manage during the next few months, they can continue on it and then reevaluate in a year. Just going back a little bit here on the support group, like I said, we do have brochure and pamphlet that we give to our patients before being discharged. Also is available in a lot of family planning and community centers. One question I had, and I think that's one of the most important questions that, can we prevent postpartum depression? Because prevention is the best medicine usually if we can achieve that. So assessing patients preconceptually or even during pregnancy, trying to identify who is at high risk of having postpartum depression. As we mentioned, some of the risk factors. If that's possible, and it's something easy to detect. It's not always is, but trying to help the patient with some of these things. Trying to even start the treatment if the patient has a history of depression prior to the pregnancy or even during the pregnancy to be started on medication. We manage the pregnancy better for her sake. And also trying to educate her on different things that, like we talked about, expectation during and after the delivery of her baby. So again, it's not always an easy task, but if we identify those patients at risk, have been evaluated during the pregnancy or even before, trying to identify the patient that might benefit from the counseling or even the therapy before or during the pregnancy to prevent the postpartum depression. This is, again, it's one of those interesting topics that, we deal with almost on a daily basis with our patients. We try to be very thorough with all that stuff with the patient as much as we can. Sometimes they can be open to discussing this, and sometimes they might not be. So I'm going to leave this to if any questions or concerns.
So if you have any questions, please, you can take yourself off of mute to ask the questions, or you can post the questions via the chat.